Hello, everyone, and welcome to Talk with the Doc, a program where we take your questions straight to one of our Providence experts and get their insight and information. I am your host, Mary Renoff, and today we are talking with Dr. Robert Gall, Medical Director of the Level 3 Neonatal ICU at Providence St. Joseph Medical Center in Burbank, California. Remember, everyone, if you have questions for our experts, please share them with us on social media. We can be found on Twitter at PSJH and on Facebook under Providence St. Joseph Health. Use the hashtag TalkWithTheDoc, and maybe one of your questions will be on our next episode. Before we get started today, I want our listeners to know that the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or treatment. And today we're joined by Dr. Robert Gall, the Medical Director of the Level 3 Neonatal ICU at Providence St. Joseph Medical Center in Burbank. And today we're talking about newborn babies who need intensive medical care. Thank you all for sending in your questions. We are going to get started right in. We're going to jump right in with my first question, which is tell us a little bit about yourself.
I'm Dr. Robert Gall. I'm a neonatologist, board certified in neonatal perinatal medicine, and I've been practicing neonatal intensive care for over 30 years. And so I also am the president of the Neonatal Hospitalist Group, which is a large intensive care group of neonatologists caring for babies in our community. And I've also worked for well over 10 years in the insurance business, doing case management for folks like Anthem Blue Cross, Regal Medical Group, and healthcare partners. So I have a pretty extensive view of neonatology and what it means to parents and society.
Awesome. Well, we're going to take our first question from Tracy, who says, what is a NICU?
Well, a NICU is a specialized part of the hospital that takes care of babies. And we define neonatology as the care of infants from birth until up to 1 month of age. So in our NICU, we'll obviously care for premature babies as low as 24 weeks, or any baby having problems at birth. But one of the other things we do in our NICU is take care of babies coming in from the community. There's not a lot of care for pediatric patients anymore. So our NICU will take babies up to 1 month of age from the outside.
Oh, wow.
So the NICU, again, is a specialized area where we do take care of babies. And it's specialized to the extent that we do not share any equipment with any other place of the hospital. Everything is specialized to the NICU. All of the nurses and physicians and respiratory therapists are trained specifically in the care of babies. So it's a highly specialized unit, and again, it's a team sport where we have a lot of people involved, so we have the best possible outcome for the baby.
You got a good roster.
Yes, we do. We have a very good team.
Well, Leslie asks us, how many babies are typically in a NICU at any given time, and how long do they usually stay?
Well, the amount of babies you have is limited to the amount of beds you have. So here at Providence St. Joseph, we have a 20-bed unit, and we can have up to 20 patients in it. Sometimes in a very busy season, we'll overflow a little bit into the newborn nursery, but that's generally the limit. And if you look at how long you expect your baby to be there, generally for a term baby with simple problems like a newborn infection or newborn jaundice, it might be as much as 7 days. But if you have a preterm baby born at 24 weeks, which is the lowest gestation that we can really do well with, you're talking staying in the hospital for 13 weeks. And, well, how come you say 13 weeks, Doc? Well, because it's going to take 13 weeks to get to 37 weeks gestation, which is normal term. And you really can't rush Mother Nature. You'll go home about the time your normal due date would be. So it means different things to different people when you talk about how long you can expect your baby to be in the NICU.
Wow. Well, Carrie asks us, do all hospitals have a NICU?
No, they do not. There are some institutions, again in Los Angeles, it's going to be hard to find one that does not have some sort of neonatal service. But once you get out of Los Angeles and you're in more rural environments, you might be limited to NICU support services. So it's very important for every mother to determine where there is an NICU. And especially, again, you want to identify, am I going to potentially need one? And that's when we talk about, well, who gets in an NICU? And it's generally considered high-risk pregnancy if you have things like hypertension, gestational diabetes, things we call incontinent cervix, where you tend to go into preterm labor for no good reason. But there's also things like multiple gestations, or if your baby has a known anomaly, such as a congenital heart, you're definitely going to want to be at a place where they're going to be able to take care of all the needs of the baby, because it might result in a preterm delivery or need surgical consultation and correction after the patient is born.
Well, he just answered your question, Lisa, about high-risk pregnancy, so we're good on that one. How expensive is a long stay in the NICU?
Wow. I usually don't like to talk about money, but since you brought it up.
None of us do.
There's two components to every bill a parent would get. The first component is what we call the bed day rate, and that's from the hospital. And that includes all the tests that are run, all the medications you receive, all the nursing care, respiratory care, social worker, pharmacy. That's all bundled into what they call the bed day rate.
Wow.
And that can be, on the low end, $2,500 a day. On the high end, depending if you're in a high acuity setting, such as a children's hospital with complex congenital hearts, $15,000 to $20,000 a day.
Wow.
So it's easy to do the math, and you can see why most people cannot afford medicine today, even if you're extremely well off,
Sure. Yeah.
because it's no way can you deal with numbers like that. The second component is what we call the physician component, and that would be what the doctor charges to take care of you. The great news is that that's generally about $125 a day.
Oh, wow.
So you can see right away that the biggest part of your bill is the bed day rate at the hospital.
Sure.
And so this kind of gets back to working with the insurance industry and managing these kinds of patients. And that's why really the actual doctor care is the smallest part of the bill. The biggest part of the bill is going to come from the hospital. And what makes the hospital bill bigger? Well, the longer you're there, the more days, the more bed days. So number one, the medical team wants to have efficient medicine so that you are not creating complications that delay discharge, and you're getting your baby out the door in a timely fashion and safely. And when you think about it, and when I do case management, I look at it as a gestational thing. In other words, if you're born at 24 weeks, I consider that you've had a great care if you go home in week 36 of life.
Mm-hmm.
That means you're actually ahead of schedule by Mother Nature, and that's as good as you can do, because the rate limiting step for going home is being able to nipple feed. And you can't do that until you at least hit 34 weeks. So if you can get a baby out from 34 by 36 weeks, you're doing a really great job. If your hospital or unit is sending everybody home at 43 weeks, 46 weeks corrected, then you're probably having a lot of complications, and the medical care is not probably going as smoothly as it could be. So when we talk about impact to society, because that's really what it is, it affects all of us since none of us can afford it, is, we talk a lot about good prenatal care, avoiding those births that result in these high number of days. In other words, you want to take 24-week preemie to 28 weeks before they deliver. You want to avoid complications in the NICU that cause what we call iatrogenic or medicine-induced problems. And that is why having a very organized, well-functioning team is so important, because they're at the bedside 24/7. The doctor comes and does rounds, but there's a bedside element, and we call it due diligence, which is really important to having a successful outcome and avoiding some of these high hospital bills.
Absolutely. So the doctor and the bedside care team might be the smallest portion of the bill, but not the smallest part of the survival rate and the success of your baby.
It's all up to the team.
Yeah.
That's what's going to rate the good medicine, and give you the lowest length of stay, and you go home without complications.
Yeah. Does Providence provide financial assistance for people who need it?
Yes. Providence is amazing, and recently we lost Sister Sheila, who was our Providence spiritual leader, and called upon her many times to assist with difficult family situations. But the spiritual component is one of the beautiful things about the hospital, and I really enjoy it, because there's not only when we talk about humans, we all focus on mind and body, but the true triangle is mind, body, spirit.
Mm-hmm.
So there has to be some spiritual component that people feel when you're in the institution. And again, we deal with people from all over the world. There are people coming from Europe and Asia to deliver a baby here. We all know about immigrants and coming to America to deliver. And so there's a lot of people who do not have the resources to literally pay for the service that we give them. So there's a lot of generosity that goes on the part of the hospital, but also the physicians, to essentially, we call them to create what you would call a charity case, where we just all agree we're not going to get anything. And
Sure.
you don't.
Yeah.
But
I know Providence is well known for providing for the poor and vulnerable.
Yeah,
so.
and that's part of the mission. And that's, you just accept it because that's the way it's going to be.
Sure.
And so rarely, if ever, do any of us look and see what type of coverage anybody has, because, again, I said at the beginning, I don't really like to blend the money aspect into it, because it detracts from, the fact that we're all here to give the best care possible to everybody, and not just based on who your insurance carrier is.
Because as Providence believes, health is a human
That's
right.
it.
Mm-hmm. Absolutely.
And they take the message to heart, and they walk the walk and they talk the talk.
Absolutely. We're going to switch gears with a question from Carrie, who says, what kind of changes and advancements have you seen in NICUs over the years?
I think we've seen a big advance in perinatal medicine, which is the ability to maintain the pregnancy. And that comes through the use of perinatologists and ultrasound machines, recognizing these high-risk pregnancies and being able to maintain them as long as possible. In the NICU setting, it's the constant technology advancements that we see in the mechanical ventilators, the equipment, the probably 30, 40 years ago, a little drug called surfactant came into the world. And we use this to improve lung function in premature babies. And the greatest advancement since then has been body cooling, which takes care of babies who have a perfect pregnancy, but at the last minute they're starved for oxygen due to complications of the birth process, and they're at risk for a severe brain injury. So the body cooling is able to decrease the metabolic rate of the body, so that certain adverse biochemical reactions that cause the brain to swell and destruction of the brain cells, which is irreversible damage, and we can prevent that from occurring. And again, that's one of the unique things that we have at this hospital. And I think for the advancement of overall care, it's truly one of the miracles that we have developed through science.
Well, this question comes from Lisa, and she says, tell me about the babies you care for in the NICU. Are they all preemies?
No, they're not. And in fact, most of them are not. Probably half of the babies are term babies. And they get into the NICU because during the labor process, when the bag of water breaks, baby's no longer in a sterile environment, and they get an infection. And infection gets into the baby as they come down the birth canal. Bacteria can enter the baby's body through the eyes, the ears, the nose, the mouth, any place where it's very vascular. And from the bloodstream, and from that penetration into the body, it gets into the bloodstream and causes an infection. And again, no, I don't want to scare anybody because we've been born this way for thousands and thousands of years. And again, when we talk about miracles, we talk about antibiotics. You used to never be able to offer anything to a baby in the bad old days, but now that we have antibiotics, infections are very easily cured. And so a lot of babies end up in the NICU due to infection. Probably the other big reason that most babies end up in the NICU are because of newborn jaundice.
Okay.
And oftentimes, again, because in our medical world, we don't give mothers a lot of time anymore. In fact, if you have a normal vaginal delivery, you're expected to go home within 48 hours. If you have a C-section, maybe you'll get 4 days.
Yeah.
But during that amount of time, you're expected to become proficient in breastfeeding and have your milk supply and be ready to go. So again, it's a little unrealistic. So a lot of people will go home with inadequate milk supply. They're dutifully breastfeeding their baby, but the baby becomes dehydrated and becomes jaundiced, and as they become jaundiced, they become more sleepy, they get more dehydrated, and they come into the hospital. And again, these can be direct admits from a physician's office, and I like to emphasize that because not only do we care for babies who are born in the hospital, but able to bring babies back from our community. It's a great support for our pediatricians. And it's pretty simple to cure: intravenous fluids, enhance hydration, and put them under a billy light. And generally speaking, they're home within 2 to 3 days.
Oh, okay.
And you spend a lot of time with the parent and get them in touch with the baby and the breast milk coming. But we see a lot of that. We see babies who are born and have retained lung fluid because all babies are born underwater initially. So there's a process of drying out the lungs. And so there's a lot of term babies. And they're about 50%. And about 35% are what we call pretermers that are 32 weeks and above to 37 weeks. And they generally have a birth weight of about 1,500 to 2,500 grams. That's 5 pounds to 3 pounds. And then the next subgroup is only about 15% of the births anymore. And that's the tiny babies, less than 1,500 grams, less than 32 weeks.
Wow.
So most babies in the NICU are not critically premature babies. Obviously, the more immature, the more complicated the case becomes.
Sure.
And then the other subgroup is babies with congenital anomalies, and that means that there's some sort of, nature's gone wrong, whether it's the heart didn't develop normally or there's a problem with the lungs or the kidneys that require attention.
We talked about bringing babies back from the community. We have a question from Aaron that talks about, do you see more babies in the NICU from a home birth situation versus a hospital birth?
Well, the answer to that is if there's no problems and the home birth is successful, we never see them. But we do see them when the home birth goes wrong. And again, that can be that the baby gets stuck coming down the birth canal, or that the placenta pulls away from the uterus. That's called an abruptia. And suddenly this perfect pregnancy has gone bad, and now the baby is starved for oxygen. And those are the cases that we see when there's a real problem. And so when it comes to home birth, I think it's really important that when a family chooses that they research it very carefully, and that they get a very competent person to be in attendance, but that you also go the extra mile and make sure you identify, what am I going to do if things are not going well? How am I going to get out of here? Where am I going to go? And again, here at Providence, we are trying to work with our community doulas and people who want that, so that it's pre-designated that if there's a problem, when they call 911, they're coming to our NICU.
Wow, okay. That must take a lot of pre-work then.
Yeah, it does. And, although birth is natural, and we've done it for thousands of years, it's not without its complications.
Sure. Well, Casey, this question comes from Casey on Facebook, who says, when do you know you need a NICU, and what's a defining moment?
Well, you need a NICU when you have identified yourself as having a high-risk pregnancy. And that's, again, diabetes, hypertension, incompetent cervix, or predisposition to preterm labor, or that you have multiple babies on board, and that's twins or triplets, or if you know that your baby has a known anomaly. And those are the ones that you know for sure you're going to need an NICU. Other than that, most people don't expect to ever be in the NICU unless you have, even in the hospital, that unforeseen complication of the delivery, or your baby gets an infection or has, a transient problem of adjusting from intrauterine to extrauterine life. So again, rather than trying to know when I need one, I think it's, working with your obstetrician to identify what problems you might be having during your delivery, so that we can be where there is an NICU. And when you're not expecting a problem and you tend to have a hospital birth, try to identify a place with an NICU.
Sure.
Because again, you do not know what's going to happen, because birthing is it's a violent experience. And so it takes a lot of planning to make sure you don't have a complication.
Well, I think that's a great transition, because our next question also comes from Facebook via Lois, and it says, if I deliver in a hospital that doesn't have a NICU and we have an emergency, what happens? Do we get transported?
Yeah, when you have most hospitals have the ability to stabilize. And that means that they can provide oxygen, maybe intravenous fluid support. But again, they don't have all of the sophisticated equipment that you would need. So we do have a transport program. And so when we get a call from a hospital that doesn't have the level of care, the level of services you need for the baby, we'll go out and pick up the baby and transport the baby in. And so most communities have the ability to have a center with a transport team to support hospitals that don't have a full-blown NICU. And so yes, you would be transferred. And the transfer generally requires the expertise of a specialized transporter unit, which essentially is an NICU on wheels. Comes with an incubator, a ventilator, sometimes a body cooling machine, and intravenous access and poles for carrying IV solutions. There's always a physician to stabilize the baby and start medical care. We have a neonatal respiratory therapist to maintain airway patency and oxygenation. And we have an NICU nurse who's starting IVs and giving medications. And it's an orchestrated event where the team operates in unison. And a big part of it is communicating with the parent the reason for why we're taking your baby out. And obviously you're going to leave the information for them so they can come and see their baby as soon as they can.
Well, you're really good at this, because you've actually got the two next questions I had were how are NICU staff trained differently, and are parents allowed to be with their baby? So maybe you can answer both.
Yeah, we are trained differently. And we are specialized, and we don't do adult CPR, we do neonatal resuscitation program. And so it's a different methodology a little bit, but it's all about establishing airway, breathing, and circulation. We call that the ABC of life. But beyond that, we all are subspecialized in the special needs of premature babies or babies that are unique to that population. So every person who is involved in the NICU will start out as a doctor or pediatrician. The pediatrician becomes a neonatologist. The respiratory therapist becomes a neonatal respiratory therapist. Okay. The nurse becomes a neonatal nurse. And so it's always advancing another level of subspecialization. We also have what are called nurse practitioners, who are physician extenders, very valuable in our practice. And these are nurses who are neonatal nurses but go on and get a master's degree in nursing and become a neonatal nurse practitioner. So it's all highly specialized and focused on babies. Wow. As far as visitation, we love parents to be there. In fact, we want them there as much as possible. We're alarmed when they don't show up, because that means something isn't right, because most mothers want to be by their baby. So we have a lot of time devoted to visitation. Every mother has a big, beautiful easy chair that she can sit in and hold her baby, because there's a lot of convalescent time. In other words, if you're born at extreme immaturity, 24 weeks, by the time you're 27 weeks, you're no longer acutely ill, and you're just marching off the calendar to 37 weeks. So a lot of time is spent with moms, and we like having moms and dads participate, because the education process occurs when they're there, so that they're fully prepared, and they're literally pros by the time they go home. they've bathed and fed and changed diapers and have embraced the role of the parent. And so we help that by having them in the unit. So it's very important. For those parents who can't be in the unit all the time, we have our NICU camera, and that's a little tiny video camera that operates on Wi-Fi. And so a live vision live image of your baby can be accessed by your telephone at home. So literally a parent can visit with their child day and night.
That's so amazing. That's so amazing. And you can share it with your friends and family.
And you can share it with friends and family. And we've
Wow.
had families from all over the world, from many, many, many countries, grandparents especially, who did not get to see the birth of their grandchild, participate in the joy of that baby and able to see them in the NICU.
Oh, that's fabulous. We have a question from Lena that says, I've heard of something called a giraffe bassinet. What is that?
A giraffe bed, we call them a giraffe bed, and it's basically 3 beds in one. We used to have 3 different beds. We had a radiant warmer, which was basically a flat space with a overhead radiant warming source. And eventually the baby would have to get off the radiant warmer and be put in an incubator, which is a little kind of plexiglass box so that the baby's temperature can be maintained. And then from there they would eventually wean out to an open crib, like a bassinet. So the giraffe bed now incorporates all 3 of those beds in one. And it's very sophisticated, so that it can be a radiant warmer, and essentially the top of the bed can pop open so that there's a radiant heat source on the baby. And this is used when you're doing procedures on the baby and you need to have complete access to the child with your hands. And that could be putting in a central line or doing a minor surgical procedure, and or your cues are caring care of the baby. The top then comes down and it's an incubator. And when the baby gets bigger and we're starting to get ready to go home, you pop the top, but it's not radiant heated, and the baby is in there as if it's an open crib. And again, they're incredible tools, and again, one of those very fantastic things that has been developed over time for the care of babies.
Well, I think you touched on this next question a little bit, but let's go a little deeper. How do you know when babies are ready to leave the NICU?
All babies have to do 3 things to go home. And it has to do with, again, a term baby can qualify much quicker than a preterm baby. But the 3 items are nipple all feeds without assistance, maintain your temperature in an open crib, and have control of your breathing. And that means brain development. So you have to be about 3, almost 4 pounds to wean to an incubator, from the incubator to an open crib. And not until 34 weeks does a baby even have the ability to start coordinating breathing, suck, and swallow. So generally, the earliest a preterm baby can go home is about week 36, because that's when the brain is developed enough to have the ability to feed. And control of the breathing, again, that's something that all premature babies outgrow by the time they're 43 weeks corrected, but you don't want to hold them in the hospital till that time. So sometimes we do what's called a sleep study, and we can evaluate if there's immature breathing patterns, and if so, we put them on caffeine, which we all know about. And it's the same as Starbucks, it's caffeine, except it's given in a different format. It's given once a day, and it helps keep the baby breathing while they're at home. And sometimes we'll send them home on a home monitor for extra insurance if need be. But those are the 3 criteria. And so early on we tell parents what we're looking for so that they can follow it with us and they're all ready to go. And I often walk in, gee doc, my baby has fed all his feeds for the last 24 hours. Am I going home?
Oh, that's
yes,
amazing.
you're going home.
They've got the checklist. They're checking it off. They're ready to go.
Checking the checklist. And again, it's all about participation, because you want to involve them in the process so that they are fully prepared and they know what to expect when they go home.
Awesome. Well, we have time for one last question. And it comes from Jesse, and it says, I've heard about a NICU milk bank. What is that?
A NICU milk bank is what we call a donor milk program. And a donor milk program is here because preterm babies, especially less than 32 weeks, do not tolerate cow-based protein. And all formula as we know it is based on cow's milk. So our preterm babies we want to have on human milk. because it's better for their digestive system. You have fewer complications. They grow better. There's better tolerance to the feeding. So we encourage every mother to participate in breastfeeding and produce milk, but not everybody can. So there now have been what we call milk banks. And we have generous people in our world that donate milk to the milk bank, and it's pooled as a giant vat of milk. And unlike natural milk, it's pasteurized. So some of the elements of living milk, which is what you really want, you don't have in there, but you maintain a much better nutrition profile of for the baby. And again, you're avoiding cow-based protein. And again, what's important about that? Well, a lot of babies don't tolerate it. They get allergic reactions to it. They have an intolerance to it and can cause things where we cause bowel disease. And so we avoid it as much as possible. So again, it's one of those things that has come into existence because of the recognition of its importance, and yet it's something that's been around for thousands of years. And when you look back in history, well, what probably happened when a mother didn't have milk and she had a newborn baby, there was somebody else in the tribe who had plenty of milk and would feed the baby. And so since we don't do that anymore, we do have milk banks. And again, that's how we have progressed over time.
Thank you, Dr. Gall, for joining us today on Talk with the Doc, and to everyone for listening and sending in your questions. We look forward to a future topic with more experts from Providence St. Joseph Health. Make sure to follow us on social media at PSJH on Twitter and on Instagram, and under Providence St. Joseph Health on Facebook. To learn more about our mission and the vital healthcare programs and social services we provide, visit future.psjhealth.org. Thank you.